Hello, everyone. I'm Carmen Pugliafito, and I'm here today with Professor Akrit Sodhi of the Johns Hopkins School of Medicine and the Wilmer Eye Institute. Akrit, welcome to Retina Synthesis.
Thank you so much for having me today.
You've done some very interesting work looking at tapering patients off of treatment and looking at biomarkers associated with treatment efficacy and differences in weaning behavior using different agents. So we'd like to really talk about your work. You had two very interesting papers in the Journal of Clinical Investigation. So why don't you just outline to us what you've been interested in and what your hypothesis was?
Sure. Well, I guess as a background, as we discussed before we started, I'm a clinician scientist, so much of what I do is in the lab, but I am a retina specialist, and I have a particular interest in learning how to identify how to best treat patients with retinal vascular disease, including macular degeneration, and how to optimize treatment for each individual patient. And what I had started to do when I first began practicing was looking at the different treatment approaches, which at the time were basically monthly treatment, treat and extend, and also PRN treatment, and trying to decide which amongst those, as many young retina specialists do, best suited their clinical needs. And I liked the fact that the PRN treatment reduced the number of injections that patients received, but at the same time, it maintained the frequent visits, which a lot of my patients didn't like. And it was also sort of more of a reactive approach, and it made the assumption that if someone was inactive, they would continue to be inactive until you saw them again. I like the treat and extend approach because it seemed to be more personalized, giving patients treatment based on how they responded to treatment in the past. But I also recognize there was for patients being overtreated if you assume that some of the patients didn't require treatment at every visit. So over the first few years of practice, I developed an approach that other people had also been exploring, which I termed treat and extend, pause and monitor, where I effectively started with a treat and extend approach. And if I could extend the interval between visits out to 12 weeks, starting with 3-4 week injections, followed by an extension of 2 weeks at each subsequent visit, assuming that the cortical neovascularization was quiescent, I would hold the treatment and I would begin what I called a treatment pause, sort of watching them closely initially and then extending the interval to watch them every 12 weeks. And that allowed me to personalize the treatment with the treat and extend approach, but still take advantage of the PRN treatment, withholding treatment if I didn't feel that the patients required it.
So what did your study find?
So in this retrospective study, we looked at those patients, and I should mention on top of that, I do collect samples from my patients for various studies, looking for novel factors we identify in the lab, or using screens to identify proteins that might contribute to either disease progression, poor response to treatment, or potentially just serve as biomarkers to identify which patients best respond. We initially looked at the patients that we had treated at one satellite office where I saw patients, and we noted that the patients sort of broke down into 4 categories. Patients that required, or effectively maybe 3, patients who required treatment every month, just patients who failed treatment extension, patients who could be maintained on treatment with no fluid anywhere from every 6 to 10 weeks, and then patients we could effectively wean off treatment. And in the initial study published in 2022, we found that the breakdown was about 20% of patients could be fell in the category where they required monthly treatment, and about 1/3 of patients could be weaned off treatment, with the remainder needing treatment regularly but responding well to treatment. And this was using a combination of available anti-VEGF therapies. In that first study, our interest was in trying to define whether a patient fell into one of those categories early in the treatment process. So we defined the patients based on how they responded to treatment after a year. That's when they were given the designation of weaned if they were 30 weeks post-treatment and still quiet, or potentially requiring monthly or more frequent less frequent treatments. We went back to our bank and we obtained samples that we had collected very early in the treatment process before we had these patients defined. And we looked through proteomics initially in an unbiased study to look for markers that could predict which of those categories patients fell into. And we found that there were distinct differences in the protein expression pattern of patients who required monthly treatment compared to patients who could be effectively weaned off treatment. We also identified a protein that was interesting to us because it was a component of drusen and implicated in dry AMD, ApoB100, but its behavior, according to its expression profile in our patients, suggested a paradoxical protective role, and we corroborated that with mouse studies. That was the initial paper. In a sort of sister paper, we published a paper in JCI Insight a few months later where we took a candidate approach. Instead of looking at proteomics and sort of screening through all the different proteins, we selected proteins that we thought might help define those different patient populations. And we focused on proteins that were regulated by a transcription factor that regulates VEGF in patients with macular degeneration and ischemic retinal disease, hypoxia-inducible factor, which is the transcription factor I work on in my lab. And we began with angiopoietin-2, since it was and remains sort of the hot protein as sort of the second hit if you're going to target VEGF, and another protein that seems to be the one that most people are targeting, the angiopoietin-2 Tie2 pathway. And what we found was that the levels were elevated in patients with AMD compared to controls, but they were at similar levels in each of the different patient populations. So whether they responded well to treatment or responded poorly, there was no difference in the levels, whether that was before or after treatment. So that suggested to us that although it might be a good target, it certainly wouldn't be a good biomarker. And on top of that, there were probably other proteins that might be regulating or contributing to the poor efficacy of current anti-VEGF therapies in AMD patients. So we looked at a couple of other proteins and we identified one called angiopoietin-like 4 that we had previously identified in patients with ischemic retinal disease, specifically diabetic eye disease. And we found that that protein actually was predictive of whether or not patients required more frequent treatments. So in patients who required monthly treatment, angiopoietin-like 4 was significantly higher than in patients who required treatment every 12 weeks or longer. The remainder of that study looked at, using mouse models, how exactly angiopoietin-like 4 contributes to the promotion of choroidal neovascularization and could potentially serve as a target. But the two studies together, we think, demonstrate how there are other players in wet AMD, and they can contribute to response to treatment and potentially be used to predict response to current treatments.
So what biomarker do you think is the most promising in looking at patients who would be able to be weaned from therapy?
So we haven't identified the set of biomarkers that we could move forward with. In that second paper, which was by Yu Chin and colleagues, we identified angiopoietin-like 4, and in combination with VEGF levels pre-treatment, it was reasonably predictive of patients who required monthly treatment. So the patients who couldn't be have a treatment extension. If the protein levels were high, there was with reasonable sensitivity and specificity, you could identify those patients, at least distinguish them from patients who could be extended. It wouldn't be at the level where it would be appropriate to use in the clinic, but it suggests that maybe what we like to define as the HIF secretome, other HIF-regulated proteins in addition to VEGF, may give us a hint as to how a patient is going to respond to anti-VEGF therapy.
Mm-hmm. So what percent of patients were able to be weaned off of therapy?
So in the initial paper with all treatments used, we were able to get 31% of patients at year 1 who were successfully entering a treatment pause, which was, as I said, defined as 30 weeks or longer of no activity. So they returned after 12 weeks, they were inactive, no fluid, no reduction in vision. They returned, and that was the first time the treatment was held. They returned again in 6 weeks just to check on them to see if an extension led to reaccumulation of fluid. And if they were dry at that visit, they went another 12 weeks. And from that time forward, they were followed every 12 weeks. If they went through those 3 visits and had no activity, it was at that point that we defined them as being effectively weaned or entering a treatment pause. So that was 31% in the first paper, the JCI paper of Cow et al. In January of 2022. We subsequently followed that up with a paper this year in which we looked at the specific therapy that the patient received. In this case, it was either Avastin or Eylea. And we looked at whether or not that influenced the success rate of extending the interval between visits and also weaning patients off treatment.
So, and what were the differences?
Well, I should tell you, going in, I was anticipating that there wouldn't be any differences. I actually anticipated, since they both target VEGF, and that prior data suggested that both were similar in their efficacy, albeit Eylea seemed to last a little bit longer and was maybe more effective in a subset of patients. I anticipated if there was a difference, it would be, as prior reports have suggested in other settings, modest, an advantage to Eylea. And what we found is a lot of the things we initially assumed were true. During the initial monthly treatment, which every patient got, whether they had Avastin or Eylea, patients did similarly. The patients receiving aflibercept or Eylea did slightly better in terms of vision gain, 5 letters or more, but overall about the same. During the extension period, which occurred after month 3, that's when there was a distinction between the two. The patients receiving Eylea were able to be extended further than the patients receiving Avastin, suggesting that the Avastin patients would fail more often with the treatment extension. And that correlated with a increased percent of patients with vision loss during that period in the Avastin group. By 1 year, when patients were all at sort of more of a steady state, or at least approaching a steady state, where we had achieved a sense of how they would respond to anti-VEGF therapy, and their interval was a little bit more regular, all those differences sort of washed out. Eylea was still, the treatment interval was longer compared to Avastin, and that's consistent with prior reports, and that's what we had expected. But the visual acuity, the OCT findings, everything else was the same. And I should mention that everything was the same prior to the studies, prior to initiating treatment. And so at that point, we thought, well, they seem to be pretty similar. The advantage of Eylea, and very similar to prior reports, was observed, but it was modest, and it was based on a slight extension of the treatment interval. However, when we looked at the success of weaning patients off therapy, this is again using the 30-week time interval as the definition of a patient who was weaned off therapy, we saw that the number of patients who could be weaned off Avastin was about 15% at year 1. And that would be year 1 plus the 30 weeks. So it could extend as far as a year and a half. And for the Eylea, it actually was 43%. So there was about a 3-fold increase in the number of patients who were effectively weaned off treatment, or at least entered a treatment pause with the Eylea compared to the Avastin. And that was really not expected, or at least I didn't expect that to be the case. When we looked at the 2-year data, albeit with a smaller group of patients, those numbers were similar for Eylea. It climbed over 50%, and for Avastin, it did get to 25 or 27% at that stage. So the Avastin didn't catch up, it improved, but there was a clear difference between the two. And that was also reflected in, not in the VEGF levels, which we checked in the patient's aqueous, but it was reflected in the OCT findings. Similar to the first study, we did 2 mass readers of all the OCTs at months 1, 2, 3, 6, and 12. And we noted that the patients who were weaned off treatment were very rapidly brought to no fluid, so no interstitial fluid, no subretinal fluid. Pre-treatment, they all appeared the same, but the patients who were weaned off treatment, within 1 to 2 treatments, they were rapidly brought to no fluid. The patients who weren't weaned off treatment were unable to get to that stage, or a large percentage were not able to get to that stage. With the Avastin versus Eylea, we found that Eylea was much more effective, even after 1 treatment, at getting patients to no fluid. That doesn't necessarily mean that's why they ended up being weaned off treatment, but we think that the initial ability of Eylea in this case to dry up the patient's CNV, or at least to cause some quiescence early in the treatment process, might influence the success later. And that might be why Avastin, even after 2 years, didn't seem to catch up.
Why the difference?
So that's the big question. That's something we're looking at now. We've subsequently done a series of proteomics studies looking at patients treated with Avastin versus Eylea, and trying to identify either markers or maybe an explanation for why. At this stage, and it's purely conjecture, we think it's probably one of a combination of things, or it's likely that even though we didn't see a difference in the VEGF levels in the aqueous, it's likely that VEGF binds stronger to Eylea, or at least longer, or the Eylea lasts longer, and certainly at the level of the retina. And we can't speak to the results if we had looked at retinal VEGF instead of aqueous VEGF. So we do think the binding to VEGF plays an important role. The how long the Eylea is in the eye is probably influencing its efficacy. But we also speculate that maybe the fact that Eylea targets more than just VEGF, that might also influence its efficacy. That we don't know for sure. We would be curious about faricimab, for example, as it does target a second target, whether that too would have a similar effect. We speculate also that some of the benefit seen with faricimab, the ability to extend up to 4 months, might be a similar ability to induce quiescence. It's possible that the same number of patients, up to 50%, don't really need subsequent treatment, but that needs to be studied.
Well, I think there are three major points here that I think are noteworthy. First of all, you've looked at biomarkers that might predict which patients are going to be able to pause. You've identified a percent of patients that can pause, and you've identified differences in the underlying treatment to the pause. So is neovascular AMD a chronic disease in every patient?
So I think, having heard some of the response to the paper, I think that's one of the concerns is, holding treatment, and, what's the consequence of holding treatment? Wet AMD is a chronic disease. And I'd like to point out that I would suggest that diabetes is also a chronic disease. Retinal vein occlusions, certainly ischemic retinal vein occlusions, also chronic diseases. And the PRN approach is a weaning approach. You effectively, or at least a stopping of treatment approach. So although I think that the word weaning may elicit a lot of concern, there's a lot of data in the literature to support the fact that in wet AMD, there are patients who don't require monthly treatment or even bi-monthly or every 4-month treatment forever. And the two important questions, the simple important question is, who are they? And I think that's a pretty obvious question. And, we would like to try to help identify them with biomarkers. I think the more important or the more interesting question to me is why? What is it that's going on in one group of patients' eyes and not in the other? Or what is anti-VEGF therapy doing in one group of patients but not in the other that allows this group to be weaned off treatment? And that's really the question we're trying to explore. But is AMD a chronic disease? Absolutely. Are these patients in, using a cancer term, complete remission? Probably not. I mean, I think that these patients are all at risk of a recurrence, and I think we need to be aware that they're at risk of recurrence. But I think, in the last 2 years, there's been enough studies demonstrating that patients who will experience vision loss. And we know that prophylactic treatment with anti-VEGF therapy similarly doesn't prevent the development of corneal neovascularization or progression from dry to wet macular degeneration. So in the absence of a clinical trial really measuring a treatment protocol in which there's a treatment pause versus one where there's maintenance therapy, until that clinical trial is performed, I don't think we can say one way or the other whether or not which approach is safer or more effective. I think at this stage, I'm comfortable with close monitoring, holding treatment as I would with the PRN protocol, using this treat and extend, pause and monitor protocol.
Are you going to continue these studies looking at some of the newer agents that are said to decrease treatment burden?
We certainly do have an interest. I think this is at a stage where, I'm hopeful that some of the larger networks would take over looking at an approach to wean patients off treatment is part of one of their protocols, to include it as an arm in one of their protocols, or whether in newer clinical trials evaluating drugs would include them. As I said previously, my focus is really on looking at contributing proteins and genes in either mediating the development of wet AMD or its response to anti-VEGF therapy, and less so on clinical trials, although that's something we are exploring at this stage.
Well, listen, thank you so much for your participation on retina synthesis. I think your work has been really indeed provocative, and I look forward to hearing more from the lab.
I appreciate you taking the time to talk to me about it. It's been very enjoyable.
Thank you.